Okay, well, welcome everyone. And my name is Deacon Fred Tora. I'm the director of the pastoral ministry for the Archdiocese of San Francisco. And I'd like to welcome you all on our third presentation on bioethics. And let's begin with a prayer. In the name of the Father, and the Son, and the Holy Spirit. Amen.
Amen.
Let us pray. God of all goodness, you have given us your life-giving word and have made your will known to us. All good giving and every perfect gift come from you. Let us respond to that generous love by living lives that are good, pleasing, and perfect. May we be formed by your word planted within us and confidently await the day we will all be gathered with you forever and ever. Amen. In the name of the Father, the Son, and the Holy Spirit. Amen.
Amen.
And good evening, everyone. And I just would like to introduce our speaker today, Dr. Joe Zalot. He is the staff ethicist with the National Catholic Bioethics Center in Philadelphia. He has been with the center since 2017. Prior to joining the National Catholic Bioethics Center, Dr. Zalot served as a regional director for ethics and spiritual care for Mercy Health in Cincinnati. And he was also an assistant professor of religious studies and ethics at Mount St. Joseph, a university in Cincinnati, and an associate professor with tenure from 2009 to 2015. Dr. Zalot also served as a lecturer at the Athenaeum, Ohio Mount St. Mary's Seminary in Cincinnati. Joe earned his doctorate from Marquis University in 2002. He authored 2 books and various articles and book chapters, and has presented at academic conferences both domestically and internationally. He's also the founder of Dr. Z Travel, which is a faith-based travel company that offers educational and parish pilgrimage trips to Europe. Joe is married to his wife, Susan, and they have a daughter, Maria. So without further ado, Joe, the floor is yours. Please mute yourself, and if you have any questions, please write it in the chat. At the end of the presentation, we'll try to get to as many questions as we can. So please mute yourself. And Joe, the floor is all yours.
Thanks, Fred. Appreciate it. And good evening, everybody, or good morning to those who are in the Philippines or at other crazy places around the world. We never know where people are. So welcome to the third week of our course through Catholic Bioethics. And it's the second week tonight specifically on end-of-life issues. So tonight we're going to focus on an issue that is quite misunderstood, but one that is out there, and it still causes a lot of ethical problems. And it's an issue that we get quite often in terms of our consult line, and that is medically assisted nutrition and hydration. So I'm going to share my screen here. Oh, hang on a second. There we go. First things first, what you're saying, this is my daughter and I, and I figure I'll wait till week 3, see if I get people mad at me. So my wife and I were both from Massachusetts, so we're New England Patriots fans. And this past week, yes, it was a preseason game, but last Thursday night, the Patriots played in Philadelphia. So my daughter and I went, and we represented the Patriots well. So if there's any other Patriots fans in the class tonight, you get an A for the course. You don't have to come to any more classes. You get an A right now. But if you're not a Patriots fan, well, then you got to do all the tests and everything. So
Jets fan.
Oh, don't get me started.
I didn't know there was a test.
No, don't worry, there really isn't. All right, so as you said, so tonight our focus is going to be what we call medically assisted nutrition and hydration. Sometimes you'll hear artificial nutrition and hydration. I don't like that term artificial, so I use the term medically assisted. Can people mute? I know there's some people who are unmuted. There we go, thanks. So again, we use the term medically assisted nutrition and hydration. And what I'm going to do tonight is I'll do my initial notes, kind of explain what the church teaches, and then we'll kind of open it up for some discussion. And then after a little bit of discussion, go back and hit a couple of topics that are very closely related to this question of nutrition and hydration. One of them is VSED, voluntary stopping of eating and drinking. And if we have some time, talk a little bit also about a question that we get quite often, and it's, patients with advanced dementia and who've either forgotten how to swallow or stopped, can't swallow or forgotten how to swallow. Do we have to provide them with nutrition and hydration? That's a question we're getting more and more at the NCBC, but that's a little ahead of our time. So let's kind of talk a little about what are we talking about here? So I always like to start off with just a little case study on this. And this is a little different. It's the first time I'm doing this presentation in a Zoom format like this, so I don't know how the discussion is going to go. But kind of keep this in mind as we go through our presentation. Can people mute? Guys, can people mute? Thank you. And this is a kind of a composite of a fairly typical consult that we'll get at the NCBC. So you have an 85-year-old man who has suffered a very serious or massive stroke. After he's stabilized and prognosis comes back, he has no higher order brain activity, but his brain stem is functional. Basically, that means that part of his brain, the brain stem that controls your physiological functions, your breathing, your respiration, heartbeat, those things, that is still intact. But the person's not able to, he's not awake, he's not able to communicate or anything else. So as I said, his heartbeat, his respiration, his bodily functions that are controlled by his brainstem, they're all functional, right? The doctor has said to the family, the doctor recommends not giving the person nutrition and hydration. That's what N&H is, nutrition and hydration. And, and says, don't worry if there's, if your dad is, he's showing signs of dehydration, which he's going to, or starvation, don't worry, we'll mask the symptoms. We'll give him morphine or whatever medications to mask those symptoms. And the rationale that the doctor gives is that if we do provide nutrition and hydration, in other words, if we feed him, the patient will develop bed sores, infections, any number of other things, and he will, quote unquote, and we've heard this, suffer horribly. So the patient has 4 adult children. 2 of the adult children say, we don't want nutrition and hydration. Just don't give him anything. But 2 children want nutrition and hydration. They fear and they express, we don't want to kill our father. I mean, that's their real fear. And so there's a, surprise, surprise, there's a conflict amongst family members. And let's say you're the ethics committee expert at the, Saint whatever hospital, and this dilemma is presented to you. And the question is, what do you do? And that's, hopefully that's what this presentation will, give you some insights to. And in fact, there's probably some people on this Zoom call tonight who, either have been in this situation where they've had to make a decision for a parent or, some other person. And so this is very real. Again, this is as people live longer, and in fact, as cases of dementia get more and more and they increase, this type of situation is going to occur more frequently. So again, what are we talking about? All right, so we're talking about medically assisted nutrition and hydration. Again, I don't like the word artificial, so I don't use it. So I'm going to say medically assisted nutrition and hydration. First of all, what is it? Right? What is medically assisted nutrition and hydration? And basically, quick definition, it's a technological method of delivering nutrition and hydration to patients whose needs cannot otherwise be met due to their medical condition. In other words, the patient is in such a condition, like our case study patient is in a situation where they can't feed themselves, right? So a technological means of bringing nutrition and hydration to him, that's what we're speaking about here. And I'm not going to just give 3 examples here. I'm not going to go too crazy in terms of describing them, but nasogastric tube, an NG tube, is a tube that goes up your nose. You'll see a picture in a second. Goes up your nose, down into your stomach, and delivers nutrition that way. I can never say this word. Percutaneous endoscopic gastrostomy, or a PEG tube. Say that 10 times fast. That's a tube that goes in. Normally, I believe it actually goes into the intestine, but it's a tube that can go stomach, intestine, and it's a means to provide long-term nutrition hydration. An NG tube, as I understand it, it's really, you can only really use it for about 2 weeks until whether complications come up that you can't use that anymore. The PEG tube is the long-term feeding tube. And then you have TPN, total parenteral nutrition. That's in very specialized situations. It's essentially a central line. And again, very, very specialized. It's not used often and can only, again, be used for a limited amount of time. So really, when we're talking long-term feeding tubes, we're talking about number 2, the PEG tubes. And you can see in this little picture here, I know it's a little bit small, so if you have to get a little closer to your screen, please do. But you see the tube that goes up the patient's nose and down into his stomach. That's the NG tube. And then you have various forms of the gastrostomy tubes, and the PEG tube is one of those. So you get a visual as to what we're talking about here. If you want to see what they look like, obviously on the left is the NG tube. It's a tube that goes down, goes up the nose, down into the stomach, and then the PEG tube on the left. So that's essentially what it looks like. A really important, just before we get into the church's teachings on this, there's actually a really important distinction that needs to be made, and an understanding of where the church is on this because of what's happening legally. And that distinction is, is medically assisted nutrition and hydration, is it a medical treatment or is it care? Is it basic care that is due to all people? And I just use these definitions here. So what is a treatment? A treatment is the application of medicine, surgery, psychotherapy, whatever the case may be, to a patient or to a disease or system. Whereas care is the provision of what is needed for the well-being or protection of a person or a thing. And again, we're in the classroom. I would always, how many people think nutrition, from the church's perspective, is medically assisted nutrition and hydration treatment or care? From the Catholic Church's perspective, it is care, right? Nutrition and hydration, providing someone with food and water, is considered basic care. It is not a medical treatment, right? And that's really, really important to keep in mind, particularly, in a medical context. And just some references to church teachings that talk about this. And this isn't everything, but it's just some of the more recent writings on it. So the new Charter for Healthcare Workers, that's actually a document put out by the Vatican, and it's applicable to the world as a whole. Section 152 speaks about this very clearly. Some of you may have heard just this past year, well, in 2020, I should say, the Congregation for the Doctrine of the Faith put out a document called Samaritanus Bonus, which has to do with end of life, a lot having to do with palliative care and hospice. And we'll talk about some of that stuff when we get to the palliative care and hospice a couple of weeks from now. But in section 5.3.2, they again make this point that nutrition and hydration is basic care. It's not a medical treatment. And finally, we'll see a quote from Pope St. John Paul II coming up in a second, where he makes this distinction very, very clear, right? So again, from the church's perspective, nutrition and hydration is basic care. It's not a medical treatment. Why is this important? Well, there are moves on in numerous states, and I'm not going to say which ones, but some states, who are looking to define or redefine nutrition and hydration as a medical treatment. Some have done it. And the reason, or one of the reasons they're doing that, is so that it becomes easier for people to withdraw it, to withhold it or withdraw it. It becomes simply a medical treatment like any other medical treatment that, like last week, one could determine is extraordinary, and so it's claimed it's extraordinary, and thus it can be removed. So kind of keep that in mind as you're as you're making decisions about this for yourselves, or if you're called out to make decisions for others. All right. So what does the Catholic Church teach on medically assisted nutrition and hydration? You may remember from, I think it was last week, when we were talking about some of the NCBC consults, and about 10% of our consults overall have to do with nutrition and hydration. And I also mentioned that, that's important just for that fact. But I also mentioned that as we're doing our Catholic identity and ethics reviews, those are the reviews of Catholic hospitals where we review policies and educational materials and stuff. What we found over the past few years is that hospitals actually get this wrong in their policies. So many Catholic hospitals, and I'm sure it's by ignorance, not by malice, but there are a lot of Catholic hospitals in their policies who get the Church's teaching wrong. And so it's kind of important to understand what the Church actually teaches on the issue. So John Paul II, back in 2004, he put out a statement, and here's the statement. You have the long name of it in your notes, but it's an address to participants in a international congress that was happening in Rome on life-sustaining treatments. And for those, there's probably a lot of people on the call who remember March 2004, although you're saying, what the heck, March 2004? This was when the Terri Schiavo situation was really starting to percolate. And it was really starting to, the press was really starting to get interested in it. Terri, very quickly, she was a young woman, late 20s, lived down in Florida with her husband, Michael. And I'm not sure we know exactly what happened, whether she had a heart attack or something else, but essentially she was found unresponsive, brought to a hospital, and she was diagnosed in a persistent vegetative state. Now today we don't use that term, it's usually kind of minimally conscious state is what they call, but that's the terminology that was used at the time. And she was a persistent vegetative state, and she was very much in the same situation as the person, or let me rephrase that. In some ways, she was in the same situation as the person who had the stroke in the case study at the beginning of the beginning of the presentation. She had, now her family disputes this, and I know her brother, Bobby Schindler, and the family disputes. They said that she actually was demonstrating some ability to communicate and whatnot. Now, again, we don't know, but from the medical perspective, her higher order brain functions she didn't really have, but her brain stem worked. So, and I always used to say this in class, telling students, I say, aside from her persistent vegetative state, Terri Schiavo was healthy. Her heart was beating. She wasn't on any kind of ventilator. If you gave her food, her body would assimilate it, it would metabolize it. She just couldn't feed herself, so she was on a feeding tube. And you probably know the story. Michael wanted to remove the tube, and the family didn't, and went to the courts, and went to the Congress, and went to the president, and it was just a mess. But it was kind of within this context that John Paul II, in an address, now, I don't believe he actually delivered it because he died about a year later and he was very ill at the time. But John Paul II kind of jumped into this fray because there was actually a lot of discussion going on back and forth. What do we have to do? Do we have to continue providing these patients with the nutrition and hydration? Yes or no? And John Paul II, in this, and you have this in your notes, it's a bit of an extended quote from this document. But John Paul II said this. He said, quote, "The sick person in a vegetative state," again, today we'd probably call that a minimally conscious state, "awaiting recovery or a natural end being death, still has the right to basic health care." And in basic health care, he identifies nutrition, hydration, cleanliness, warmth, etc. So it still has the right to basic health care and to the prevention of complications related to his or her confinement to bed. Okay. I should particularly like to underline how the administration of food and water, even when provided by artificial means, medically assisted means, always represents a natural means of preserving life, not a medical act. Again, so John Paul is being very, very clear from the Catholic perspective. Nutrition and hydration is not a medical treatment. It's not a medical act, although putting in a peg tube, certainly that is a medical act. But feeding someone is basic care. It's a means of preserving life. It's not a medical act. And then here's the money line. And recall our discussion from last week about ordinary and extraordinary, because it comes back. That's why we did that first, and now we move here. Its use, right, to nutrition and hydration, even by medically assisted means. Its use, furthermore, should be considered in principle ordinary and proportionate, insofar as and until it is seen to have attained its proper finality, which in the present case consists of providing nourishment to the patient and alleviation of his or her suffering. Again, the key here, and this is when this document came out, this caused a huge stir, is this underlying section. Its use, furthermore, should be considered in principle ordinary and proportionate. And as we know from last week, if a treatment or an intervention is deemed ordinary and proportionate, then there is a moral obligation to accept it. So basically, if you take what John Paul II said and applied it to Terry Schiavo's situation, what the Pope was saying was that we have a moral obligation to continue to provide Terry with nutrition and hydration, even through medically assisted means. She had a peg tube, so a tube that went right into her, either her stomach or her intestines, one of the two, right? So John Paul II said this. Well, this set off a firestorm. Because there was, again, before this, there was discussion back and forth. In fact, I believe the bishops of Pennsylvania put out a statement, or the bishops of Pennsylvania and the bishops of Texas had differing statements on the issue. So John Paul II said what he said, and again, caused a lot of confusion. So what did we do? What did the bishops do? Well, the bishops do what the bishops do when there is a question. They send what is called a dubia, questions, to Rome. And the process for doing so is they send questions to the office, the Congregation for the Doctrine of the Faith. And I think I mentioned that the Congregation for the Doctrine of the Faith, or the CDF, either last week or the week before. Actually, it was the week before, because we looked at a statement from the CDF on the vaccine mandate issue. The CDF it's the Vatican's theological office. It's the office that I describe as, it's the office that makes sure that what's being taught as Catholic theology actually is Catholic theology, right? What's taught as church teaching really is church teaching. So it's a very, very, very important office. And again, one of the things that this office does is when bishops have questions or a dubia, they respond to the questions. So in 2005, so John Paul II's allocution came out in 2004. The US bishops sent the CDF a dubia in 2005, asking two questions, which we'll see in a second. And in lightning record time, 2007, and this is the church here. My goodness. 2 years later, the Congregation for the Doctrine of the Faith responded to the U.S. bishop's question. In this document you see here, responses to certain questions, blah, 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 concerning artificial nutrition and hydration. So what I'm going to do here is I'll give the bishop's question number one, then we'll give the CDF's response, and then we'll give bishop's question number two, and then give the CDF's response. Okay, so in light of John Paul II's allocution from 2004, the U.S. bishops sent a dubia asking two questions. Here's the first question they asked. Is the administration of food and water, whether by natural or artificial means, to a patient in a vegetative state morally obligatory? Now, in your notes, you've got the rest. There's more to the question, but this is the essential part of the question. Is the administration of food and water, whether by natural or artificial means, to a patient in a vegetative state, i.e. Terry Schiavo, is it morally obligatory? And the answer from the CDF came back, and they said, yes. Right? The administration of food and water, even by artificial means, is, in principle, they're essentially repeating John Paul II's 2004 statement. It is in principle an ordinary and proportionate means of preserving life. It is therefore obligatory, right? As an ordinary means of care, it is obligatory to the extent to which and for as long as it is shown to accomplish its proper finality, which is the hydration and nourishment of the patient. And here's the key. In this way, suffering and death by starvation and dehydration are prevented. This is why, right? We know that if we remove Terry's feeding tube, which they ended up doing, what's going to happen? Well, she's going to die. She's going to die either of, well, she's going to die of dehydration before she dies of starvation, which she did. But that's what's happened, right? That's what the nutrition and hydration prevent. They prevent the person from dying. All right, so the answer to the first question is yes, it is ordinary. Providing nutrition and hydration is an ordinary means of care. Question number 2 from the US bishops. Again, think of this in the context of Terry Schiavo. When nutrition and hydration are being supplied by an artificial means to a patient in a permanent vegetative state, may they be discontinued when competent physicians judge with moral certainty that the patient will never recover consciousness. In other words, Terry Schiavo, she had been in this state for 15 plus years. There's no reasonable expectation that she's ever going to have any kind of meaningful recovery. That being the case, may we discontinue the nutrition and hydration? And this was the argument of Terry's husband, Michael Schiavo. Response from the CDF, no, right? You can't remove them. A patient in a permanent vegetative state is a person with fundamental human dignity and must therefore receive ordinary and proportionate care, which includes, in principle, the administration of food and water. Right? So the CDF, in their response to the US bishops' dubia, they basically restated and reaffirmed John Paul II's teaching from 2004. So we have a moral obligation to provide nutrition and hydration, and it's deemed an ordinary, in principle, it's deemed an ordinary means of care. So in this document, and if anybody wants it, I can send it to you. Maybe I should have sent it along with Fred, but we can get it if anybody wants it. But the document was 7 pages long. What we just saw is essentially the first page. And then they went into about 5 or 6 pages of giving some background on the church's teachings. But then at the end, the CDF gives some exceptions. Now, the church, they never use the word exception. They use, big fancy language. Basically, what they're talking about is, yes, there's a moral obligation in principle to provide nutrition and hydration. However, there are certain exceptions to this rule. And the exceptions are pretty, they're very logical, as we will see. And they identify 3, although for some reason, I can't get this to go. There we go. All right, so the exceptions to the obligation to provide nutrition and hydration. First one that they mentioned, provision of nutrition and hydration is physically impossible due to location or circumstance. All right, so let's say, for example, that, and I don't know why we would be doing this, but let's say we were crossing the Sahara Desert in a Jeep or something, and that's going to take like a week to do. Something happens to someone and someone is in need of medically assisted nutrition and hydration. If it's impossible to do because we don't have the equipment or anything to do it there, is there a moral obligation to provide it? The answer is no, there isn't. We can't be held morally responsible for something that we can't do, right? So that the CDF, the church, recognizes that if it's physically impossible to do something, there's no moral obligation to do it. Secondly, if the patient is not able to assimilate nutrition and hydration, they can't digest it, they can't metabolize it, right? If, and I'll try to be as delicate as I can, a patient who is very ill or someone who is approaching death is given nutrition either by mouth or through a feeding tube, and that nutrition essentially runs right through them, and you can use your imagination on that. Right? If their body's not able to metabolize, assimilate the nutrition and hydration, there's no moral obligation to give it to them. In fact, you're probably, if you did insist on giving it to them, you're probably actually hurting them and causing a burden. So again, if the patient's body's not able to assimilate, there's no moral obligation. And lastly, and I'll give some examples in a second here, but the CDF says if the method of providing nutrition and hydration, i.e. the feeding tube, is excessively burdensome to the patient. So again, we're going back to this ordinary, extraordinary means of care. So the CDF doesn't give examples, as I said, I will in a sec, but they recognize that if the means of providing is, if a patient, if it's excessively burdensome to the patient, then there's not a moral obligation to do it. So the US bishops take that, take the response from the CDF. And, I forgot to bring my copy of the ERDs, the Ethical and Religious Directives, my bad. I mentioned this again last week. The Ethical and Religious Directives for Catholic Healthcare Service, it's a document published by the US Conference of Catholic Bishops, and it's essentially a foundational moral guide for providing healthcare in a Catholic healthcare institution. And there's 77 directives, and Directive 58 has to do with, or Directive 58 is the one that deals with nutrition and hydration. So what the US bishops did, and you have the entire Directive 58 in your notes, I'm just going to summarize it here. But what they did was they went back and they rewrote Directive 58. And this ended up being, this one change was the 5th edition of the Ethical and Religious Directives, which came out in 2009. So the US bishops went back and, based on John Paul II's guidance and based on the interpretation of the Congregation for the Doctrine of the Faith, they rewrote this directive, and this is the guidance that Catholic healthcare in the United States has today. So basically, what is our obligation? In principle, we have an obligation to provide food and water to a patient. Again, it's basic care, right? It's not a medical treatment. We have an obligation to provide people with food and water, even medically assisted nutrition and hydration, if they can't eat or drink on their own. It is permissible, however, here's the exceptions. It is permissible to withhold or withdraw medically assisted nutrition and hydration if, one, the patient cannot assimilate it. We mentioned that already. Two, the means of providing nutrition and hydration constitute an excessive burden. And I give some examples here. Now, these examples are not in any way, shape, they're not complete. They're illustrative more than anything else. So, for example, let's say a patient is on a feeding tube, and they're experiencing repeated aspiration pneumonia. That's when the what is in your stomach comes up your esophagus and it gets into your lungs. Not a good thing. All right. If that is happening, that constitutes an excessive burden. That can be an indication that this is an extraordinary means, and it can be withheld, as we talked about last week. It's possible here in the Western world, probably not so much, but it's also possible that the site of where the tube enters the patient's body could be, it could experience recurring infections there. That's a possibility. That's another that's another factor that could indicate an excessive burden. And the last one I say, because we hear this one fairly often, and people can disagree with me on this. We've had situations, people asking, particularly a patient with dementia, who they'll insert a feeding tube, but the patient constantly pulls it out. And in fact, what would have to happen is that in order for the tube to stay in, they would have to essentially strap the patient down, strap their arms down, so they can't move. Now, for me, that is a line. That's a line that if you have to do that, I would say I think you're in pretty good, you're on pretty solid ground for saying that this is an extraordinary means of care. But again, we could talk about that. But anyway, so if the provision of the nutrition and hydration constitutes or causes an excessive burden, it can be withheld or withdrawn. Last one is that the U.S. bishops speak to is that if death is imminent, and the implication here, death is imminent due to the underlying condition. So say a patient is end stage, terminal cancer. If death is imminent, right, there's not a moral obligation to provide nutrition and hydration. If the patient is hungry or if the patient wants it, you can, but there's no moral obligation to do so. And as we know, as patients move closer to death, they need much less in terms of nutrition, they need much less in terms of hydration, and the church recognizes that. So if death is imminent, and in imminent we're talking hours, day, maybe day or two. We're not talking weeks. I mean, in reality, all of our deaths are imminent, depending on how you define that. But if, we're talking hours, day, two, patient's not hungry, they're not demonstrating any signs of dehydration or anything else, there's not a moral obligation to provide the nutrition and hydration. But the key here is the withholding of it is not what's going to cause death. What's going to be the cause of death is the patient's underlying medical condition, right? So with, in principle, just to summarize, there's an obligation to provide food and water, but there are situations that the church recognizes that it can be withheld or withdrawn, right? But those situations are very, very, very specific. So let's go back to our case study here, and if people have some questions, we can talk about it. It's going to be a little weird probably, so maybe more of a Q&A than anything else, because we're all over the place here. But again, so go back to the 85-year-old male who's had the stroke. Brainstem is functional, but no higher order brain activity. Terry Schiavo-like. Doctor recommends don't do nutrition and hydration, and don't worry about it if he's starting to feel uncomfortable or feel the effects of dehydration or starvation. We'll give him medication, and we don't want him to suffer horribly. There's disagreement in the family. Two people say yes, two people say no. What would you do? So I'm actually going to stop right here, and I'm going to stop and give you guys an opportunity. It's 10:37. It's a little later than I thought. Comments either on the case or questions that people may have. And then if we run out of questions, Mary, then we'll go on and talk about some of the other stuff. I want to get people involved here a little bit.
Mary, do you have any? There's questions.
Yes. Maureen Lundy, do you want to mention your question? Maureen?
Yes.
Good morning.
Hello, everybody. I'm thinking of elderly people who would like to die at home.
Mm-hmm.
And it can be very difficult to get appropriate home care to come in and to be reliable, and something like artificial feeding. I'm not a nurse. I don't know how difficult that is to do at home. If it necessitates putting the person in care or in hospital long-term, because if you're doing this kind of feeding, you have no idea when death is going to occur, apparently.
Mm-hmm.
What about the person's wish to die in their own home? Could you talk about that a little bit, please?
Yeah, the difficulty with doing a kind of a presentation like this is that every situation is unique. And so what you have to do is apply these principles, these teachings to every particular situation. There's different perspectives on that. So I have heard, so if a patient is at home and they're not able to eat or drink for whatever reason, and a feeding tube is indicated, I mean, that's the first thing is to determine, whether this is indicated. Now, certainly putting the tube in, at least a PEG tube, that is a surgical procedure, so that would have to be done in a hospital. Following that, and if there's any, gastro GI docs or anybody on the call, I'd like to speak more about this from a medical perspective, please do. Patients do go home with them. Family members can be trained to provide the nutrition and hydration. And from what I've heard, and again, I've never done it personally, but people have said once you figure it out, it's not that difficult a thing to do. It's not as, it sounds like, oh my goodness, there's this big tube and everything else. It's really not as involved as, people may fear it is. That being said, what you have to do is look at it, and I'll just say from consults, there's questions about, well, what about the burden of transporting the patient to the hospital? and that can be a burden as well too. So what you have to do in these situations is really really look at each individual situation as an individual situation and apply the principles, apply the ordinary and extraordinary calculation to it. Bottom line is what the church is asking is, or what the church wants, or what the church desires, or what the church teaches, is that we don't want someone's cause of death to be either dehydration or starvation. That's kind of the bottom line here in terms of what we want to do. Now, how do we best navigate all of the various variables and all the various factors? Again, it's an individual type of situation that you have to look at. So I know, Maureen, I'm not giving you the 100% clear question clear answer, because there isn't one. You really have to look at each person's individual situation.
I think Marilyn Baker, who's a nurse, I think she responded somehow to Maureen's question by saying that a tube feeding can be provided in the home setting, and she's a nurse, and PEGs can be placed in an outpatient clinic setting. So I don't know if that can help in answering Maureen's question. So
it seems to me, though, that there's Maureen's question has a little bit more, and maybe I'm wrong, Maureen, but I'm just going to say this. First, Joe, I have fed people with a feeding tube, and you're right. Once it's established, it's a very easy way to feed someone. I'll just say that. But like when my grandmother was old and she was living with my parents, and we knew she was old and she was dying, and there wasn't even a discussion of putting in a feeding tube at all. But every day there was a little bit of water, using a spoon. They just did what they could, but it never occurred to us that there was a moral obligation once she couldn't, she was just getting more, that we had to put a feeding tube in to sustain that life any longer. Mm-hmm. And that's the part that's a little bit confusing to me, because I was also in a situation where a person was dying of Lewy body syndrome. It's a form of dementia. Mm-hmm. And towards the end of his life, the family was caring for him and they were feeding him, but he was gagging he couldn't swallow. His body had forgotten how to swallow. Right. And there was an argument in the family, good Catholic people, and they were telling his wife that she had to put in a feeding tube. And to me, that was just really confusing, because he was going through the natural process of dying. Right. Nobody was killing him. Right. But that was part of the human body dying, is it closes down, functions close down. And so it's confusing to me in a way, because it seems like you are saying that if someone gets to the point where they can't, that we have to put in a feeding tube. But isn't it the natural process of dying that these functions stop? I don't know if I'm making my question clear. I don't know if that adds years, Maureen, or not.
No, actually, what you're saying, and actually, Marianne, what you're actually doing is jumping ahead to what I was going to mention at the end. So we can just do it now, so it actually works quite well. So going back to the context of what we just talked about, so the John Paul II statement, the Congregation for the Doctrine of the Faith's response, and the U.S. Bishop's rewriting of Directive 58. The primary context for that is a person who is like a Terry Schiavo type situation, right? A person who is they're very ill. Let's just put it that way. They can't feed themselves, but the expectation is that if they're given nutrition and hydration, they will live, for however long they'll live. I mean, Terry Schiavo was not dying, so that's really kind of the context for that. Excuse me. The question is, okay, now how do we relate all of this to a situation where a person is actually, is dying, is in the process of dying? And it's a tough one. I can, from my experience in consults, it's these types of questions that are probably the most difficult, because you have family members who they want to do the right thing. That's the thing. We want to do the right thing. But we don't want to cause pain or discomfort or burden to our loved one, but at the same time, we don't want our action or our inaction to be the cause of the person's death, right? So how do you balance all of that? And just in terms of, well, a couple of things. You are correct that as, and I think I mentioned this before, and again, I'm not a medical professional, but having spoken to a lot of people concerning end-of-life care, as a person moves closer to death, they do need, their need for nutrition and hydration, it lessens, like falls off the table. I've had consults where people have said, my grandmother, my aunt, or whoever the person is, she hasn't eaten anything for 2 weeks, and she's still hanging on. And it's, the body's burning fat and things like that, but the nutritional and hydration needs are much, much, much less. And so that's one of the first things that people need to, to kind of keep in mind. That like, oh my goodness, grandma's not eating 3 meals a day, like she's going to starve to death. And it's like, well, no, right? In terms of the dementia question, this is one that's been debated back and forth, and I don't think anybody knows the answer, fully. But we at the NCBC work very closely with the Catholic Medical Association, which is very fantastic organizations. And I've had conversations with physicians about that because we get these consult calls. And I say, you have a patient who is, late stage dementia. They have, as you said, they have forgotten how to swallow, or their body has forgotten how to swallow, or they can't swallow anymore. Do we have an obligation to provide those people with medically assisted nutrition and hydration? And the answer that I always get is, well, that's the first thing. But usually the response, and these are from very faithful Catholic physicians, the basic response that comes back is, generally speaking, we don't give these patients a feeding tube. And the reason is that, as one doctor said, and I think this made the most sense to me, he said, when a person forgets how to swallow, or their body can't swallow anymore, he said that's really a threshold into, this is end stages. I mean, death is imminent. And as we saw before, the US bishops have said that if death is imminent, there's not a moral obligation to provide nutrition and hydration. So practically speaking, when people consult calls, and I've probably had this conversation with people, I got to think 15, 20, I don't know, maybe up to 30 times over the past few years, this exact issue, late stage dementia, do we provide nutrition and hydration? They haven't eaten anything for 3 or 4 days. What I always say is this, I say, are they comfortable right now? Yes. All right. Don't insist on putting in a feeding tube or anything else. However, because it's the end of life and everything else. However, ask their doctors and actually ask the nurses, it's really the nurses, ask the nurses to monitor them and to see if, and let us know if the patient starts to exhibit any physiological signs of dehydration or starvation, because, the body will say things. And I say, if that happens, maybe try something. And I said, if you get, wait a couple more days, if you start to see those signs, and you still have questions, or the doctors won't do, you're having trouble with the doctors, give me a call back. And I always give people my cell phone number. I said, here's my cell phone number, call me back. Of the 25, 30, however conversations I've gotten, I've never had anybody call me back. So my guess is that in each of these situations, the person really this was end stage dementia, and the person died probably shortly after I had the conversation with the family. And as I said, I think that's probably the best way to go. But it's tough because, you have people who are decision makers for their loved ones. I mean, think of, it's your father, it's your brother, it's or your mother or whomever. And they're really scared. They're like, oh my goodness, I don't want to not do something that's going to cause the person's death. But it's tough. They're tough situations. Anyway.
We have a question from Nelson Lau. Nelson, would you like to ask your question? Nelson. He asks, does the autonomy wish of the patient make a difference?
Mary, you cut out there for a second. I didn't hear the whole thing.
Does the autonomy wish of the patient make a difference?
Legally, medically, or ethically?
How about all of them, Joe?
Well, Legally, I mean, legally, we can't do something to someone. Because, a PEG tube is a surgical procedure. It's an invasive procedure. Legally, we can't do something to someone who doesn't want it. That's battery, right? We can't do that. So legally, does autonomy, a person's decision, does that play an important role? Absolutely. Medically, we're sort of in a world now where autonomy is run rampant. We'll talk about this when we get to assisted suicide. Yes, I call it assisted suicide because that's what it is. But medically, we live in a world where, patient autonomy, whatever the patient wants. So in that case, yes. Ethically, however, if a person is, there's a reasonable expectation that the person would benefit from a feeding tube, and either that person or their designated decision maker says, no, I just, don't want it. Just let me die. Ethically, there could be some real issues with that.
All right. Bridget Casey.
I
Bridget?
wrote it before that, but you didn't read it.
I'm sorry. iPad, what's your name?
I'm Marianne Rusnak. My name doesn't show up for some reason on my iPad, but I wrote a statement about a professor, a scripture professor I knew. Do you see it? Where he requested that he only wanted what people in third world countries would receive, should he be unconscious, brain dead, whatever. And so his community did that when he had a severe stroke, and he died very peacefully. I visited him and so forth. But all they did was use like a wet sponge to wet his lips, that kind of thing. And they said, it would be very easy for us to give him an IV or whatever. But his request really was his identification with the poor. And he didn't want to be given anything in addition. And he said he was at peace with dying. He wanted to be with God and with the saints and the angels. And he really did not want anything additional. Now, I found it a very moving and thing that his community honored his request. And his sister, who was a nun, was with him. Many of us were his students and visited him. But I realized with what you're saying that the institutional church might have had a problem with that. His community decided to honor his request. Can you comment on that at all?
Yeah, it's one of those we'd have to have a lot more detail, in terms of what was going on. What was? Did you say he had a stroke? Is that what it was?
Yes, a severe stroke, and was unconscious. And I guess the brain function wasn't there. He was like 70 years old, and they said he had specifically left that request that not be given anything but what you would get in third world countries. I thought that was a very spiritual, almost mystical, like identification with the poor. Yeah, and so,
Yeah, I mean, again, it's the devil is going to be in the details on this, and I guess the question is, and I'm not, I'm not making any judgment one way or the other because I can't, because I don't know the
Sure.
particulars of the situation. I guess the question would be, you said it was a severe stroke. Again, what does that mean? What would he, would nutrition, the question goes back to, would nutrition and hydration, would it have, given him time to recover at all from the stroke or anything else? I don't know. Again, those are factors that would be taken into consideration. Another factor that would be taken into consideration is what was his, and I'm not asked, this is more of a rhetorical question than anything else, so please don't feel the need to answer it, or even if you can't answer it, but the question would be, well, what was his cause of death? I mean, was the cause of death the, for lack of a better term, the consequences of the stroke? Or did he die of dehydration, or did he die of starvation? My guess is probably it was more the consequences of the stroke, but these are the details.
But he could have lived long. He could have lived longer, probably. But I'm thinking like about personal conscience here. like a person of his stature who is a rather famous scripture scholar, would have understood what he was doing and was very clear about it. And I think there's still, even with the church's statements, there's always the piece that's the individual conscience, or the conscience of the people who are making the decisions as well. But I think it's still important. I mean, none of us found it offensive that he was dying that way. We just considered him kind of a saint, actually.
Well, what she said is one of the things that I'm point out and trying to make. Because he has to be cared for like people in a third world country, does not mean that nobody tried to feed him if they could. I mean, they took care of him. If you were in a third world country, these people would take care of you. Or it's like with they took care of you. They put water in your mouth, so gave you, alleviated your pain and stuff. And it seems to me that's where, and maybe that's what you're saying, Joe, that's where the hard line is because I know people who've read these documents and they insisted on inserting a feeding tube, and it ended up in a rather painful, horrible death for the person after, because they insisted on feeding them. But if you just want to die at home, you're not saying you want to commit suicide. You're just saying, I don't want to be put in a hospital. I don't want all of these, a respirator or a feeding tube or anything. I just want to peacefully die at home. It seems from what is being said here in this class, that's not allowed.
No, that's not what we're saying.
I don't think that's what we're saying.
Well, that's why I'm trying to get clarity, because these documents seem to say that if a feeding tube is going to help the persons live longer, you're obligated to put it in. And if the person who's dying saying, no, I don't want that. I don't want to just go on living because I can. I want to, yes, be comfortable, but I want to be at peace and I'm ready to go.
I think, Marianne, a lot of this is going to revolve around what is the intention of the person who's doing this. So one of the things, and if you go further, if continue going in the notes, one of the practical concerns with all of this is that in people's advanced directives or in POLST forms, today they are legally allowed to say, you know what, I don't want any nutrition, hydration. I don't want any, don't want any of that. They can categorically refuse it, which becomes problematic in situations like Terry Scheichel's type situation, or in others as well too. What you're talking about is and again, we got to know the details of what's going on here. So if a person is terminally ill and they want to die at home and they come home and they are not experiencing, I'm assuming that they are conscious or they're awake or they're alert enough to be able to express these concerns. If, I heard a doctor say one time, if the patient is decisional, it's very simple. Are you thirsty? Drink something. If you're not thirsty, don't. Are you hungry? Eat something. If you're not hungry, don't. So in those types of situations, if a patient comes home and they're conscious and they're in end stages of whatever illness, disease they have, death is imminent, and they're not feeling hungry, they're not feeling thirsty, and they don't eat or drink anything, and there's probably no moral issue with that whatsoever. What the church is simply seeking to do here is to say, all right, we're all going to die, right? And again, it's threading the needle. It's a really tough situation sometimes. What the church is simply saying is what we're trying to avoid, what we're seeking to avoid, what we don't want is for the cause of death to be dehydration or starvation. And we're seeing this more and more and it kind of going the other way with this. We're seeing this more and more in the medical community where, people who are elderly, people who have dementia, they're just, the medical community is just saying, oh, to heck with it. We're not giving them anything. We get calls from hospice providers. This will be a couple of weeks down the road, who say, I enrolled my loved one in hospice, and they said, well, we're not going to feed them anything. Once you go into hospice, or our hospice, this particular hospice, we're not talking about hospice in general. But this particular hospice, we just stopped doing anything, any medications, any food and hydration, everything. We just stopped. And it's like, whoa, what's going on here? So that's the, we're in this spectrum of all sorts of different situations. And the question is, what's the answer? And with all end of life situations, there's no one set answer. It's, we really have to look at the specifics of a person's situation and try to help them determine, what is the best and most, what is the best choice, and, and assure that choice is within the teachings of the church. Mary, we got more? This is good, I think. I hope.
Yes. Bridget Casey, would you like to ask your question? Bridget?
Sure. Most of this question, the answer has already been answered with your last discussion. But taking that further, I'm a former hospice chaplain, and I would have a patient, slowly passing, no longer eating or drinking, but the family wants the feeding tube. And the family member is now the POA because the patient can no longer communicate. Hospice doesn't usually go in and put a feeding tube at that point because it would be considered a treatment as far as the hospice view. Morally, are you obligated to do it because the POA is saying they want it done?
Yeah, that's a good question. You guys are asking like really easy questions tonight. Thanks, I appreciate it.
I thought, Bridget, you said that the family member is not a POA.
Oh, no, I'm sorry. The family member is the POA because the patient can no longer make decisions.
Right.
Okay.
Yeah. And Bridget, again, we hear that from both sides that, the hospice is not providing something and the family wants it. And it's like, what's the right thing to do? I guess the question that you would have to answer is, again, what's the condition of the patient? What would happen if, all right, let's say we do follow the family's request and we do a feeding tube. Is that going to be a benefit to the patient? Yes or no? Is that going to be a burden to the patient? Because as people have said on the call, when someone is particularly at end of life, if you, I don't want to use the word force, but if you introduce nutrition or hydration in a situation where it's not needed, that can actually cause greater discomfort and greater pain for the patient, which we don't want to do either. So I guess the question that you would have to, and this is where, sometimes I think medical people or medical staff and family members may be talking past each other, is, overall, what's in the best interest of the patient here? Is the nutrition and hydration, is it going to be any benefit to them? Is it going to cause them discomfort? Is it going to cause them a burden? And try to figure that out as best we can. Generally speaking, I would say that, from what doctors have, in many conversations that I've had with doctors, is that when death is imminent, so if we're talking patient is actively dying, i.e., body systems are shutting down, there's really not, there's certainly no obligation to provide nutrition and hydration. And in fact, you could actually be causing the patient more harm.
Yeah. Okay, good. Because that's the way it's been explained. I've heard nurses explaining it to the family members, but I just wasn't sure on the moral issue. So thank you. That answers my question.
Now, Denise Allen, you had a statement that I think is interesting. Would you like to make your statement, Denise?
Sure. I was wondering why, if someone is not going to recover or they're in a vegetative state, why we're prolonging their journey to be with God. I wouldn't want to be that way. And then on a side note, I have been the POA, just so happens my family calls me the sister of death for 4 family members and my boss. And in all cases, I talked to them about their wishes before, and hospice was fabulous. And palliative care was fabulous, and they did everything we wanted, what we all discussed together before hospice, you know, before he was in a state, or she was in a state where they couldn't make decisions on their own. And then for my boss, the one that still conflicts me to this day, is that he had an aneurysm, and he came out and he couldn't walk or talk. And his children lived in San Diego. So I was here taking care of all the needs. And he was starting to make progress. Physical therapy was coming. They were getting him up. He knew who I was. And his children stopped treatment. They stopped food and water for him. And it was very, very hard for me, because then I'm the one there. So I'm the one with him. And even the nurse also was Catholic. And so her and I would give him, you know, little teaspoons of water in his mouth and you know, whatever. That was very hard when the family doesn't want it. And you think that, you know, sure, he's not going to make a full recovery, but he was going to make some recovery, but they chose to withhold food and water. That was very hard. That's it.
There's a lot there. What I start responding to a question or questions. Oh, Denise, you went away. Come back. There you go. Yeah, you can't ask a question and then run away, like, or you know, shut the
Sorry,
video
I'm all
off.
red.
We can't tell. What happened to this patient, this man who you talked about?
It took 10 days and then he passed.
Of what? What was the cause of death?
On his death certificate, it said complications from aneurysm.
And what did he really die of?
Starvation, dehydration. Yeah. It was awful.
That's the answer to your first question. So, you know, I said, like, for someone like Terry Schiavo or anything else, why is it that, you know, why does the church say, and it's not just the Catholic Church, it's you know, it's many others as well too. Why is it that we have a duty to feed them? Well, because if we don't, what's going to happen? Well, she's going to starve to death, or she's going to die of dehydration, which is what she did. And
well,
the family.
I'm sorry.
Go ahead. No, go ahead.
When Mike was awake and asking for water was the part that was hard. Once he was asleep and they were giving him morphine, it wasn't hard.
Okay.
So I think that was like the last 2 days.
All right. But so in Terry Schiavo and in other type situations, Terry Schiavo was not dying. You know, it sounds silly, and it is kind of silly, but, you know, putting aside her minimally conscious or her persistent vegetative state, she was otherwise healthy, right? Her body was, you know, was functioning. You know, if you gave her the food and water, all of her physiological systems were working. Her family was willing to, in fact, the family told her husband, Michael, they said, you know, divorce her and let us take over, you know, we'll take over the care of her. They believed
I remember the case.
Yeah. And she was, you know, and they believed that she, you know, that there was the possibility of some sort of recovery. And so, but what happens? Well, I guess the question would be this. So would it be okay? Let me respond to your question by asking a question. Would it be okay for someone to go up to Terry Schiavo or anybody who's in that situation and give them a lethal overdose of medicine so that they will die? Would that be okay? I think most of us would say, no, that's not okay. But what you're doing, so that would be suicide or euthanasia by commission. You do something to cause the person's death. By withholding nutrition and hydration from Terry Schiavo or from the person, you know, the gentleman you mentioned who had the brain aneurysm, what you have is what John Paul II called euthanasia by omission, right? The person you're committing you're not, instead of actually doing something to cause the person's death, what you're doing is you're not doing something necessary to maintain their death, but the intention is the same. The intention of not providing nutrition and hydration to Terry was her death. I mean, that was the only reason why they would do that. And so that's really the reason, is that by not providing it, the cause of death is going to be, as it was in the case of your of your friend here, it's
I
going
guess
to
I'm
be
still
starvation.
conflicted. I'm still conflicted because if I'm in a vegetated state,
Mhm.
I have, my husband and I went to a lawyer and we did our medical directives. And it was actually an argument because he's like, oh, you should do everything. And I was kind of like, I'm at peace in my faith and my relationship with God. So if I'm not going to wake up and I'm not going to get better, I want to go.
Well, the question is, are you the bottom line question is, and this is a question that two bottom line questions. What is the cause of your death going to be the underlying medical condition or conditions that you're experiencing? Or is your cause of death going to be starvation or, dehydration or starvation? That's a question. And in fact, I remember having a conversation with, it was interesting. There was a mother in this time, I think it was a dementia situation. There were 3 brothers. And brother number 1 called me, and brother number 1 is the one who wanted to he wanted to do the nutrition and hydration, okay? Brother number 2 was on the fence. I talked to him secondly, and we had a very interesting conversation. So brother number 3 is the one who wanted to remove nutrition and hydration, and he called me third. So I got to talk to all 3 of the brothers. And finally, in the end, I said, his name wasn't Robert, but I'm just going to say Robert. No, his name, we'll call him Fred, because, I got to pick on Fred here. And finally, I said, okay, so Fred, basically, it sounds better saying starve your mother to death rather than dehydrate your mother to death. It just sounds more powerful. I said, ultimately, Robert, you're okay with starving your mother to death, because that's what her cause of death is going to be. And there was silence on the line, and he's kind of like, he was thinking about it, and I think that's what it is. From the church's perspective, the church is very logical and very consistent in its teachings, which is one of the things I really appreciate about it. And this is one of those areas where it's very logical and very consistent. If you remove, like in a Terry Schiavo type situation, if you remove the nutrition and hydration, the cause of death is going to be dehydration or starvation. For people, end stages of cancer, heart disease, whatever the case may be, the cause of death is going to be their underlying medical condition. And it's 2 very different things. It's what is causing death. And I think that's what that's what the church asks us to keep our eyes on as we're making these decisions, particularly when you're making these decisions for someone else. And it's tough. And people, people call us up in consults and they're really conflicted. It's like, oh my goodness, what do we do? And it's tough. And this is about, I got to be honest with you, this is like, particularly the dementia patient, end stage dementia patient, this can be about as tough as it gets, to be honest with you. Anyway.
On a final note, I just wanted to say that 3 of the family members that passed, Deacon Fred did the service for.
Boy, now I have a comment, but I'm going to hold back on it right now. So.
Thank you, Joe. Thank you, Denise. Mary, is there any other questions?
Yeah, Diane Hurst. She's the one who had a statement. Are you a nurse, Diane?
Yes,
Diane
I am. Yes.
So why don't you tell us your statement? I thought it was very interesting.
Oh, I was just to the earlier discussion about, I think it was about if someone wanted to be at home, but they had the PEG tube. And as being a home care nurse for a number of years, it is something that is quite doable to teach someone how to do it. And sometimes there's intermittent feeding. It's not 24 hours where it would be a certain hours of the day. And then you have a home care nurse that's still supporting you. You can call if you have trouble in between, but you would go out once a week to assess the site, make sure there's no infections, assess for vital signs. But it is quite doable to have somebody be in the comfort of their own home, surrounded by their family, and you can teach a caregiver or a spouse or other family member how to do it.
Actually, Diane, can you, I don't, and I'm going to put you on the spot here, and this is
Sure.
maybe it's unfair to do so.
That's okay.
Could you address, being a home care nurse, could you address, and I'm not trying to paint a broad brush here, but hospice, because we've run across some very, very good hospices that will do, you know, whatever they reasonably can in these types of situations for patients who are in hospice. But then other hospices or people will say about hospices that, you know, when they enroll their loved ones, they just say, nope, you know, no more food. If your loved one can't eat anything anymore, that's it. They don't get anything. Can you talk about that, or any other people who may be on the call who are work in home health care or in
Sure.
hospice? Speak to that a little bit. Enlighten me too.
It was in the past that I did home health, but our home health agency, if a family or a patient decided to go with hospice, we would transfer the case. So the transfer, we'd give report. But I have been in my personal experience with my mother who passed away, and we had hospice. She was at home at my brother's, but also with other patients. I would follow up with family members, patients, how are they doing? And was very pleased with the hospice care. I know that it's not universal, but the quality of the care, the compassion. And I found that hospice didn't want to do certain treatments, but they always told us, like with my mother, they would treat the condition. My mother was dying of cancer, but they said if she fell and broke her hip, we wouldn't want your mother to be in pain. So of course we would transfer her to the hospital, stop hospice temporarily, let her have her hip fixed so she wasn't in pain. Then she'd come back home and resume hospice services. So that was like the example they gave my siblings and myself for that. No, we're still going to care for your mom, but we just, you know, for her cancer, we're not going to do chemotherapy, or we're not going to do, you know, any radiation therapy or aggressive treatments, but we're still going to care for her.
Did they say anything to you about nutrition and hydration?
No, because that wasn't an issue.
It wasn't an issue. Okay.
The hospice
Mary,
company I worked for, they didn't pull nutrition and water, but as soon as the patient couldn't take water or food is when we just said, don't force the patient to take it. Yeah, so it wasn't that we withdrew everything.
I would like to add my comments on hospice.
Please.
My mother had 6 years of dementia. Her dementia was probably not Alzheimer's. It was probably clinical depression. In the beginning, she had to have shock treatments, which helped her snap out of the state that she was in. She was getting shock treatments probably every 6 weeks. And she was staying at one of the nursing homes here because she refused to come in my house. So difficult that she was, 2 years or 3 years into this, I was asked, they wanted to put her on hospice. And so I'm power of attorney, my husband's a lawyer. So I said I wanted to talk to the hospice people. So we had this meeting. And when we were at the meeting, I had one question for them. What about my mother's shock treatments? They said, oh no, no shock treatments. That comes to an end. So I said, thank you. We won't use hospice. It was difficult. She lived another 2 years after that and ate and didn't have problems with food. When she did finally pass away, it was aspiration pneumonia, which is what a lot of these patients have. But I was very not happy with the hospice here in Chicago, by the way. Bye.
John, you have is that a hand? I see a hand. Oh, you're muted though. You're muted. You're still muted. There you go.
I was just going to say, in response with Kurt, as I understood it, it's not a hospice decision. It's the fact that Medicare and the insurance will not pay under treatment. Hospice is final care. The other word is palliative, I think. Palliative, because my wife was in hospice and then back to palliative to get a cyst removed and then back into, but the guidelines for treatments all seem to come, they never said they were making the decisions. They said that's what the Medicare allowed. And I don't know if it makes a difference. how old you are, what your insurance is. But that was the issue we ran up into a lot.
Mhm. Yeah, Julie has a question relevant to that. Julie, did you want to read your question? Okay, so she says, what if the treatment part, the tube and medical supervision, were to cause excessive financial burden to a family?
Yeah, I hate this question. Going back to last week, in terms of ordinary and extraordinary means of care, cost is one of the factors that we are, that we take into consideration in terms of a specific treatment. I would hope that it's not the first, it's not the the primary consideration that we take into consideration, but it certainly is. I remember actually when the Terry Schiavo thing the situation had ended. Let's put it that way. Terry had died, and I was at a presentation, and there was a priest who was talking about this, and I asked essentially that question. I said, let's say I go home and found my wife had a heart attack and she's in the hospital, and she's in Terry Schiavo's situation, and she has a peg tube, and after a year or two or whatever, the insurance says we're not going to cover this anymore. Do I have a moral obligation to mortgage my house? Do I have a moral obligation to to go to blow through my retirement, to blow through my daughter's college fund? And that's a tough question. I think probably most people would say no, but then what's the alternative? Essentially if my wife comes, or maybe she would come home, or ultimately what is she going to, especially if we couldn't continue the tube feedings, what would she die of? So cost is, it certainly is, it's one of the elements, but I would hope that it's not a primary, but it's a tough one.
Now, Mary Gundling, you had an interesting question. Mary? She asks, are you there? Oh, there you go.
I'm just wondering how common it is for people who are in the hospital when they die and they have the hydration and food being withheld, if they list that as the cause of death, or do they kind of hide that from everybody?
That I do not know. I honestly.
Do you ever ask your clients what the death certificate said when you're wondering about it? Because I would imagine that they don't put that down very much at all.
Well, seeing as we know that in certain Western states like Washington, and I don't know about California, that if someone dies by assisted suicide, by law, they have to put down on the death certificate that the cause of death was their underlying medical condition, not that they killed themselves. Now, what happens here, I do not know. I mean, when we're just in terms of being able to ask people when we're talking, when we're doing consults with people, the loved ones most often are still alive. We do get some sort of post review, maybe a year later, somebody they're kind of having a crisis of conscience about a decision that they made or didn't make, and they called us back, but those are kind of few and far between. So as I said, most of the time the people are living, and people have concerns over the type of care that they're getting. So it's a great question. I don't know the answer to it, but it's a great question.
It's just that we had a lot of clients who were older and their parents were dying, or we had a lot of people who had this situation, and I'd always ask them if they had a good death, and they would look at me funny, and they'd tell the story. And there were I live in California, many times when I wondered, what really happened there? And maybe the family members didn't really even understand what happened.
Well, just if you kind of spark something, because I sometimes I tend to be a little snarky with responses and stuff, and I've had people call up who have been on consult duty, and they'll talk about, now again, we're only getting one side of the story here, but they'll have some very serious concerns with the type of care that their loved one is getting, and nutrition and hydration is one of them. And so I've told people, I say, start out being nice, but if it comes down to it, I said, you could try this. Walk down to the loved ones in the hospital, walk down to the corporate offices and demand to talk to the hospital president or CEO or the chief medical officer and tell them this. Say, my loved one is upstairs. I'm not happy with the care they're receiving. I think they need nutrition, or I think they need hydration, whatever the case, the doctors refuse to do it. Tell them, I said, if my loved one dies, I'm going to request a coroner's inquest. And if the coroner's inquest comes back that my father died of dehydration, fill in the blank. And I don't know if, I told that to a person once, and she was kind of snarky too. So it was good. Like, we got along very well. I don't know if she did it or not. But if you are the, well,
I've done it.
Good for you. I mean, if, whether you're the power of attorney for a person or not, if a loved one is, if you think a loved one is not getting, whether it's nutrition, hydration, or anything, if a loved one is not getting the care that you think that they deserve, be aggressive with it. Hey, stand up for them. And if the doctors are going to play hardball, if the hospital's going to play hardball, now here I am, I'm kind of trashing hospitals and doctors here now, but if they're going to play hardball, play it back. Yeah. And the thing that they fear the most is the lawsuit, and just play their game. So, I'm getting snarky at 11:30 at night. So.
Yeah, so I think we should end it. I think it's 11:30. And it's late. So I know there is so many questions that we can't get to, but hopefully maybe next session, if we have extra time, we can get to them. And you can also email Joe, but not tomorrow. You can email him with your questions. And man, this is very informative and very stimulating discussion. Mm-hmm. So next week, Joe, what are we looking for?
Next week, what are we doing next week? Oh, we're doing advanced directives next week. So
advanced directives. Okay.
Healthcare power of attorney and living will, and we may get to POLST if not. But you guys have been good tonight. This is a good. I like this. It's good discussion.
This is great discussion, and thank you also. Let's end with a prayer. So, in the name of the Father and the Son and the Holy Spirit. Amen. Loving God, let us gather the many graces that were experienced here during this gathering into an inspired and committed community dedicated to those who are terminally ill with their families and caregivers. We ask for a special blessing upon those who are currently transitioning from this life to everlasting life with you. May they be treated with dignity and receive the tender and loving care they need. And most of all, may they leave this earthly life and into your arms, feeling worthy, wanted, and loved. We ask this through Christ our Lord. Amen. In the name of the Father, and the Son, and the Holy Spirit. Amen. Amen. Well, thank you all for coming. Thank you, Joe, again, for this wonderful and stimulating discussion. And have a great and blessed evening, everyone. We'll see you next week, God's willing. Take care. Thank you, Mary, for your help as always. Take care.
Thanks, Mary.
Bye-bye.